Good evening, everybody. I would like to kindly welcome you in this special event. This time only for you, our special guest, Oksana Pyzik from UK. Hello, Oksana.
Hello.
Thank you for accepting my invitation for our Pharmacist Vaccinate Forum in Poland. And today we're going to talk about something amazing, actually, because there's a big problem about vaccination hesitancy among the healthcare professionals. And Oksana is a UK expert, a global expert, actually on vaccines. And thank you very much one more time for accepting the invitation. Oksana, could you just tell us a bit about yourself, how you got involved in the vaccinations?
Yeah, sure, of course. So, hi, everyone. I'm a pharmacist licensed here in the UK. And during the pandemic, I actually led the vaccination training for our pharmacy students. So currently the laws in the UK are such that pharmacy students are not allowed to vaccinate, but I led the first initiative in the country for them. Under the emergency regulation, they became non-registered vaccinators. And throughout that period, I also had, because my area of specialty is within global health, and I am a media fellow with the Association of British Science Writers. I did quite a lot of media engagement, speaking to all the major networks across the world about vaccines. And we had live Q&As because there was so much fear and confusion. And during that time, I remember being on BBC Question Time, and the kinds of questions we were getting from the public in England were like, can I open the window, or will I catch COVID that way? So one of the things that I think we take for granted sometimes is that as healthcare professionals, we do have this level of knowledge, and there is therefore a kind of power and information asymmetry between healthcare professionals and the public. So after many years of speaking to the public about the benefits of vaccination, but also training our pharmacy students, as well as our early career pharmacists in this domain. This is one of the subjects that I think healthcare workers can have, not just pharmacists, but across the Health Professional Alliance, the biggest impact. So it's one of the things we can do to help the most amount of people around the world.
That's amazing. Do you know, by any chance, what are your vaccination rates at the moment in England against COVID and flu?
So it's interesting because since the COVID pandemic, we have had a drop in both flu and COVID vaccines. I think because the urgency has in some sense past. People previously were very motivated to be vaccinated because they wanted to get out of lockdown. They want to go to their favorite restaurants again. And so now with what we call the boosters, these are what will now be available annually. So some people don't even refer to them as boosters anymore because they may have not had that initial course anyhow. So in that regard, I don't have the exact numbers offhand, but it has gone down. We know that for sure. And that boosters are now viewed as something that, first of all, not everyone can even get in the UK. So unlike in the US, where a younger adult, like adolescents can get it, it is no longer recommended in like children and adolescents in the UK. So that's another like change as well. So I have had quite a lot of parents who have, unless of course you're immunocompromised or high risk group, but I've had parents that don't quite qualify, their children don't quite qualify under that domain, that are trying to find ways to get the vaccine. And I've actually had to tell them to go abroad to get it.
Wow, this is very interesting. In Poland, unfortunately, we have a big drop rate, unfortunately. Although the number of pharmacists is quite high who got qualifications, unfortunately, between 2,400, 2,600 pharmacists actually perform the vaccines. And unfortunately, the service is not as popular as it used to be during the COVID-19 pandemic. Obviously, the money is also going down. And I think one of the research we've done recently is also that the big hesitancy is among the pharmacists in Poland, which means that you cannot provide a quality service when you basically don't believe in vaccines. But anyway, today we are going to talk about it. And I'm really looking forward to this session with such an expert like yourself. It's just amazing. One more time, thank you so much for having us.
Thank you so much. So I think we'll move on to the presentation. There it is. Now we can see the slides.
Perfect.
Thank you, Piotr, for inviting me here today. I'm absolutely delighted to speaking to all of you from University College London here in the UK. As I said, I think this is one of the most important interventions that pharmacists are increasingly becoming involved with. So here, what's interesting is by 2026, all of our pharmacy students will graduate as prescribing pharmacists. So that is quite a big change, and it means that we've had to also adapt our curriculum to prepare students for that. So they're going to be pharmacy trainees, and they're also going to be prescribers. We've also been vaccinating pharmacists for flu, travel, and now COVID since the pandemic anyhow. In other countries, that level of scope of practice varies. So the more that we can move the needle in this direction, I think the greater the public health impact. So hopefully we see that other countries also expand their scope of practice to help improve vaccination rates. So we're going to be, this topic, vaccine hesitancy, is very timely. I know a lot of my colleagues in the US are watching very carefully what will happen, because of course we've had the new administration come in with government and some pretty interesting choices who will be leading the Ministry of Health. None of that's been confirmed, but I can say that over here in the UK, there's quite a lot of speculation about what that's going to have for the overall science environment, not just for pharmacy itself. Also, just a note, I've put my Twitter handle on here, or as they call it now, X. So if any of you are also active, then do have a follow, and very happy to engage in future conversations through that forum as well. Okay, so the next slide, we're looking at vaccine hesitancy being one of the largest threats to global health. And this was in 2019, identified by the World Health Organization. So even before the pandemic happened, the WHO had signaled vaccination rates are going down because of vaccine hesitancy, and this is a top 10 global health threat. And one of the reasons that they identified it as such a big threat is because measles was increasing by factor 5. So 5 times greater increase in measles cases. And as we know, measles is completely preventable through vaccination. The largest rise in cases we saw was in WHO region of Europe and the Americas. And this was again due to inadequate immunization coverage. Whereas in other parts of the world, so particularly sub-Saharan Africa, immunization coverage rates were low for other reasons, not because of beliefs about vaccines, but because of barriers, including access and availability. But there's nothing new about vaccine hesitancy. It's a very complex and challenging issue, but it essentially, since the very first vaccine was invented for smallpox in 1796, vaccine hesitancy was alive then, and it is alive and growing now because of mediums such as social media, which can accelerate that in ways that previously was not possible because that technology did not exist. So let's look at the definition itself. So vaccine hesitancy is defined as a delay in acceptance or refusal of vaccination despite availability of the services. And this is, again, the definition provided by the WHO SAGE, or Strategic Advisory Group of Experts on Immunization. Part of this umbrella term means that it includes people who refuse to vaccinate or are delaying to vaccinate. They might even accept vaccines, but are still uncertain about it, even if they have it. And some people might accept routine immunizations, but reject others. So this is a very broad spectrum. And I think it's important to clarify that it's not a black or white issue. It's not simply about being anti-vax, because there are a spectrum of attitudes that can change over time and across different contexts. So if we look at some of the 3 C's, and these are some of the underpinning reasons for vaccine hesitancy, let's look at confidence first. So people might not trust the vaccine. And if we look at the COVID-19 vaccine as an example, the mRNA technology, people felt that were vaccine hesitant reported that they weren't confident because they thought that it was developed too quickly. And that in that sense, they didn't understand the development process, or the fact that actually mRNA vaccines have been researched for decades before, and that they will have they've already had promising results, even in cancer research. And we should be watching that space very carefully because of the success in the clinical trials there. So such factors can affect confidence in vaccine, trust in the safety and systems. Complacency. So this is a different angle. It could be that they perceive that they have low risk associated with the disease, but also it could be that in general, their particular disease there have been so much high vaccination rates that condition is now like nearly eradicated. So a good example of this is actually polio. So people in areas where certain diseases have become rare due to successful vaccination programs may not see the need for continued vaccination. So in a sense, vaccines become victims of their own success. Many people will just not remember what an iron lung is and the devastation polio caused. So that can lead to complacency and a perceived low risk of the infectious disease. And then we also have convenience. So this is where there might be physical barriers, like if it's in a rural region and there aren't many clinics. And this is much more prevalent in low and middle income countries and developing areas. But other things can also be language barriers, costs, all of those things. And that's, again, a bit different to belief about medicines. Whereas about making the vaccine the easy choice by making it easy to get to. But then there's also this idea of collective responsibility. So an individual gets vaccinated to protect vulnerable members of their community, protect the elderly, immunocompromised, their family members, their friends, their colleagues, and they have the understanding of the importance of herd immunity and decide to vaccinate to contribute to community protection. So where we know herd immunity is really important are for things like measles, whooping cough, etc. Okay, let's go to the next slide. Right, so this is a great representation of the numbers of lives saved by vaccines globally. So that number, if we look at the first bar at the top of the chart, is approximately 154 million over the last 50 years, and with the most significant gains and impacts seen in children under 5. So this just demonstrates the profound effect on life expectancy, significantly reducing mortality and morbidity from preventable diseases. So when we look at in Africa, it's reduced global infant deaths by 40%. That's huge gains in life, and this reduction exceeds 50%. The WHO also estimates that if we can save an additional 1.5 million lives, so we can prevent that level of death if there was higher global vaccine awareness, coverage, and efforts. So there's, again, if we had better coverage, better awareness, 1.5 million deaths annually every year could be prevented. And it's not just about life expectancy itself. We also see that healthy life years, quality of life, is another really important public health metric. And over 10.2 billion healthy life years have been added globally over the last 5 decades. So the efforts not only improve individual health, but also contribute to overall healthy life years gained. And so this is the 20th century, one of the largest and most important public health achievements. In 1980, we were able to eradicate smallpox, with the last case of it being identified in India. And that took many years to achieve, despite having the vaccine for some time. And that, again, is just in the difficulty of reaching everyone who's impacted and creating a ring of defense, vaccinating those as many people as possible. There are also, of course, economic benefits. So an analysis conducted by the CDC in the US, this is the Center of Disease Control, showed that routine childhood immunization programs between 1994 to 2023 saved $780 billion in direct costs and 2.9 trillion in societal costs by preventing illnesses and deaths. So it's not only about, now we've talked about extending life expectancy, enhancing quality of life, but also there is the economic benefit of ensuring we have mass immunization programs. So what we see here is essentially a map of the world. And this data is gathered from the Wellcome Trust Global Monitor. They're located here in the UK, actually just down the road from my office. And this is a survey that was conducted to see the percentage of population that agrees that vaccines are essential for children. And this is in 2019. So again, remember, this is pre-pandemic. And at that point, we see that actually it's quite high. Globally, we can see the dark blue represents the strongest level of agreement, and the green to almost white areas are the least in agreement countries. So you can see that the Global South has this very strong agreement because they also see the devastation of the most number of children dying from diseases as a result. So they have a better understanding of the consequence of not vaccinating. And there is that visible north-south divide where, again, more countries in the South, you can see, have a stronger preference for vaccinating children. Again, the economic benefit. So every $1 invested in vaccination, particularly in developing regions, returns $16 in healthcare savings and increased economic productivity. Okay, so this previous slide was from 2019. We saw high levels of trust, especially in developing regions. However, post-pandemic, we are seeing a dip, not only in the boosters, but in routine immunizations, flu immunization, all across the board. and an overall increase in vaccine hesitancy. So I've highlighted some studies that have shown the data on this. If we look at the literature itself, even the concept of vaccine hesitancy pre-2021, the number of research papers published on this topic was only 1,160. After 2021 onwards, this increased almost fourfold to 4,563. So this is a large number. And globally, 60.8% reported increased willingness to vaccinate for other diseases, whereas 23.1% reported decreased willingness due to pandemic experiences. And often this is also linked to kind of a backlash of countries that had mandates. And there were in most countries some form of lockdown in different shapes or form, in different shapes and forms. So flu immunization, if we look in the US, decreased post-pandemic, even in patients who had severe flu, enough severe flu to be hospitalized with flu. So we see that in those severe cases, over 35% of the 264 patients who were hospitalized because they developed a severe case of acute respiratory illness, they still had worries about efficacy and safety. So in that instance, we see that number is still true for people who do get sick from respiratory illnesses. They still have questions about flu. That number is even higher from people who generally have not experienced severe levels of flu. And we see a higher number also of parents who are hesitant about giving their children the flu vaccine. Also, in terms of global trends, we see that there was a higher drop in vaccine uptake in high-income countries compared to middle-income countries. So again, I'd refer you to read some of these papers that this data is extracted from. Okay, and so this data is extracted from a publication in Nature, and it shows how over time, with the first COVID vaccines, so for the first doses, the willingness to take it. So that's category A. And then B, we see that this is now moving on to boosters. So if we compare the willingness, for instance, of high-income countries that is in orange. So in section A here, in orange, we have 87.5% who are vaccinated, at least one dose. That drops drastically when it moves on to the booster doses to 63.3%. So over time, we see that has gone down. And then category C also shows the spillover effect, where routine immunizations are also impacted. Now, it's important to state that there is a difference between high income and low income countries, because we know that there was a lagging effect with the fact that in some cases routine immunizations were not able to occur due to the lockdowns and other things that were occurring at that time. So some of that in terms of where access prevented childhood immunizations, in that category, we see the vaccination rate going back up again. But that's separate to the group that had not an access problem, but is more linked to their beliefs about vaccines. And if we now go to global variations, so this is an umbrella review of systematic reviews and meta-analysis that showed a moderate COVID-19 vaccine acceptance rate of 63% in the general population. Again, this is globally. There is a lot of difference when we compare it at a different national level. So there's significant heterogeneity, implying considerable variability in reported acceptance rates across the studies. Healthcare workers, interestingly, again, if we take the average, so that's going to be skewed. It's only slightly higher than the general population. But for instance, if we go in the US and we look at the data for health workers there, doctors and physicians had the highest acceptance rate at 98%, whereas pharmacists had 94% in the US, but nurses had 78%. So even within the different type of healthcare worker, we see that there's a different rate of COVID-19 vaccine acceptance. Chronic disease patients, unsurprisingly, they have some of the highest acceptance rates globally because they tend to be often at the highest risk. Another high risk group, however, that has low acceptance is amongst pregnant women. So that tells us that we need to have very targeted interventions for this particular group. And then parents consenting for children just below the global average. And again, here I'm just showing some of the data from the survey about the regional differences. As I said, averages mean that you're taking quite a broad spectrum. But if we zoom in on different countries, these are the ones with the sort of reported lowest acceptance rate. And that also means that these countries should have a more comprehensive, not only in terms of research to understand the level or the reasons behind vaccine hesitancy within their own population, but so then that responses can be tailored appropriately. Because in Kuwait, we may see a different type of intervention compared to France, for instance. And then if we contrast that with highest COVID-19 vaccine acceptance rates, we see that countries like Ecuador, 97%, Malaysia, Indonesia, all very high levels of acceptance amongst these groups. If we then go on to determinants of vaccine hesitancy, again, this is quite complex, and it certainly it requires response from all actors within the health communities because they have interactions with patients. And there can be 70 different factors, but the individual metrics where studies showed that vaccine hesitancy was reported most frequently and with the strongest association, the following groups were identified. So vaccine hesitancy was stronger in rural populations, amongst women, in female gender compared to men, amongst lower income, lower education, and also groups who refused the flu vaccine. It made sense to some extent that they would also refuse the COVID-19 vaccine. But these were the groups that reported the strongest level of vaccine hesitancy. We saw in terms of which countries, and these are sort of the sub-demographics within that. I think it's also important to highlight, however, that vaccine hesitancy occurs in all demographics. That's not to say that this is the only groups. And also there is still a big research gap in terms of engaging with those who have the strongest oppositional views. So we shouldn't make assumptions based on this because highly educated patients and people can also host vaccine hesitant views. So if we then see, again, early days of the pandemic here in the UK, vaccine hesitancy was strongest amongst certain ethnic minority groups. And this is a study that was conducted by what was formerly Public Health England and is now the UK Health Security Agency. So we can also see that amongst a Black population, they had the strongest levels of vaccine hesitancy compared to white British. But across all minorities, there were higher levels of hesitancy. And this was particularly important and concerning for the government because this group also faced higher mortality risks. So ethnic minorities face 10 to 50% higher mortality risk compared to white British individuals. And if we're looking at the year 2020 in itself. As a result of this, interventions to work with cultural leaders, religious leaders to boost vaccination rates was instigated, and this did have success. So those numbers did improve after the interventions, but it does show that you need to have also targeted strategies. So Environmental. This is also, if we're looking at the determinants of vaccine hesitancy, it's very complex. We showed that some of the demographics are associated with socioeconomic levels, with low income, more likely to be associated with vaccine hesitancy. But there are access barriers as well, lack of information, little promotion. For instance, now at this period, there aren't as many booster campaigns across all nations when it comes to COVID-19. And there is also the backlash against some of the mandates that were previously enacted. And personal. So this is where it gets to be about individual beliefs. But if we looked in the UK, we saw that the highest group of vaccine hesitancy was amongst the Black community. However, in African Americans in the US, there is a real historical basis for this distrust. And this also needs to be addressed directly. So you may have heard of the Tuskegee syphilis study, which was conducted from 1932 to 1972 and involved 600 Black men who believed they were getting treatment for bad blood. In reality, the treatment for syphilis was deliberately withheld, even though penicillin was available. It had been available since the 1940s. The doctors of this trial wanted to study essentially how does the decline of someone who has syphilis, they wanted to track and better understand essentially how someone's health deteriorates with this particular infection. So obviously deeply unethical, and it caused severe harm and deaths, exploiting a vulnerable population without their consent. But the legacy of this study fostered deep distrust in the medical system, particularly among African American communities, and it remains a major force of vaccine hesitancy today. It also highlights the need for transparency, informed consent, and cultural sensitivity in healthcare to rebuild trust and address hesitancy. We cannot ignore the dimension of exploitation here, targeting low-income Black men and exploiting a marginalized population for research. We cannot ignore that these types of practices and other forms of bad actors have occurred throughout the history of the medical profession. It needs to be properly addressed so that we can rebuild trust, particularly amongst these minority groups. And then another area is social. So this, again, if many people in your own group network don't get vaccinated or follow anti-vaccine platforms, you kind of get even put into this algorithm of being fed more and more information and misinformation about healthcare. There's also stigma and discrimination. So one example could be Mpox. People can deter getting the Mpox vaccine if they feel they're going to be stigmatized by it in certain countries and certain settings more than others. The WHO worked very closely with the LGBTQ community in order to increase and tailor their messaging for those who are most at risk of developing Mpox. So all of those things also need to be considered. And remember, Mpox, formerly known as monkeypox, the WHO has changed the name due to its discriminatory labeling. So that's an important thing to also highlight. But just for clarity, that's what we're talking about. And it was labeled a public health emergency of international concern twice already. So one to keep your eye out for, and also ensuring that the high-risk groups do get the vaccine. Then there's also people who have safety concerns, particularly around how long it took to make, also their additive ingredients. So some will cite that the excipients are toxic, mercury, etc., without actually realizing that many of those excipients are in other products that they consume, even foodstuffs, all the time. But it is one that you should also understand what the root cause of the hesitancy is. So again, how do we respond to this? Educating all healthcare workers about the reasons behind vaccine hesitancy is key. I mean, the literature shows that healthcare workers are highly trusted by the public still, even though perhaps less than in previous decades, but that level of trust is still high, and that there's a real opportunity to help with behavior change. So here at UCL, actually, we have a vaccine champion curriculum that was developed in partnership with University of North Carolina and Monash, so that all of our pharmacy students across the US, Australia, and here in London understand why people might be hesitant and how actually it is good for people to have questions about vaccines. We don't want to shut them down. And there are, it is good to have critical thinking around such interventions. Also targeting specific groups. So again, mothers, because they are high risk, and they can also, if they are pregnant, then they can, their children can receive passive immunity. So studies from the US show that when you had targeted education-based interventions for mothers, they were more likely to get the vaccine when pregnant and for their children. And Cleveland Clinic, again, based in the US, had pregnant healthcare workers, so doctors and pharmacists, all talk about themselves receiving vaccines and showing those videos, putting that out there as well. So that also resulted in an improvement in uptake, which is, of course, really important. And understanding those root causes so that you can better adapt the consultation. There are some good frameworks that you can use for vaccine hesitancy out there. Aspire is one of them. So the A stands for assume. So assuming a positive intent. Obviously, this is not going to be working for those who are truly anti-vax, but we've defined vaccine hesitancy as someone who, you know, might just not be sure. They might just have questions. So assuming positive intent to set a constructive tone. Sharing, S is for sharing the key facts and trustworthy sources. So directing them to where they can find that and away from platforms like TikTok. Although, again, during the pandemic, the WHO did not only triple their communications team, but for the first time, they had their communications department sit alongside the executive committee and the director general to make all shared decisions, because communication was so central to the response of the pandemic. And they started to change their style such that it was more amenable to the public. Whereas previously it would be in a very formal, almost patriarchal way of delivery. They started to engage to the public directly on all the social media platforms. So that's another thing to keep in mind. The I stands for initiating potential concerns. So there are risks and there are adverse effects. And so discussing those in a fact-based way, rather than pretending they don't exist, is also a recommendation. Responding to their individual question. That's what, so R stands for respond, and E stands for empathy. So empathizing that they may have some concerns and building trust with the patient. In other countries, we've already covered how religious leaders are a great champion, and that in certain countries they have helped with increasing uptake of vaccines. Even having things like mobile vaccine clinics outside of churches and mosques has been successful. And in other countries, text reminders, letting people know when they're eligible. This had the highest success rate in those with high digital literacy. So the countries that responded best to text reminders and technology-based interventions were actually US and Nigeria. In low-income settings, incentive-based programs, such as even things like cash transfers, did boost vaccination rates. But obviously, this has a sustainability and scalability problem, and it's not going to be appropriate everywhere. This was mostly limited in low-income settings compared to other countries. Okay, we'll go to the next slide now. So again, the multi-sector approach, healthcare workers absolutely cannot do it by themselves. Doctors can't do it on their own. Nurses can't do it on, pharmacists can't do it on. All the sectors need to work together. First of all, we need a reformed regulation around social media for misinformation, especially medical misinformation. There is no regulation of social media at this stage. So they have very little accountability in the legal system. And that is one of the obstacles, even to the extent that you could be selling fake vaccines on social media, and it would take quite a lot of publicity and for it to be taken down and for the seller's account to be closed. Unfortunately, this is something that I have in my other areas of research and work on falsified medicines have come across. So it really, in that sense, people can even die from getting medicines off of Facebook Marketplace and other platforms, and the parents can still see that that seller is still active. So that is a big part, as well as changing things like legislation so that in other countries where pharmacists can't vaccinate, we can expand that scope of practice. We also not only need a multi-sector approach, we also need to be looking at improving the research. So only 53% of countries have high quality data on attitudes towards vaccines. So we need to ensure that academia is engaged in researching this subject to have a better understanding of what motivates behavior change. Some of the evidence or lessons learned from the pandemic is that fear tactics are not necessarily effective, and that healthcare professionals should acknowledge risks rather than downplay them. Also, governments can improve access to vaccination by making just the system less complicated. As soon as you improve convenience, you also have an increase in uptake. So ensuring that out-of-hours service are available, that there are clinics, that other types of non-registered healthcare professionals could potentially also be immunizers, and forms of like reminder systems have all in the literature proven to improve vaccination rates. So we talked about, again, how working with other stakeholders is really important. I'm just highlighting some data from the Pew Research Center. This is, again, based in the US. And still, the highest level of trust was amongst healthcare professionals with information about COVID-19. But right number two, like the second after doctors or primary care physicians, was actually clergy and religious leaders. So you can imagine the healthcare professionals and clergy working together can close that gap. And as we talked about the evidence where minorities in particular had the greatest level of vaccine hesitancy, conversely, we see that when religious leaders were involved, particularly among British Muslims, vaccination rates increased significantly. So early hesitancy from 30 to 50% went up to 75% for this particular minority group. And that is a faith-led initiative. We also had pharmacists who worked with the government to try and recruit more ethnic minorities within clinical trials themselves, because often they're underrepresented there as well. And you may also recall that Pope Francis had urged Catholics to consider vaccination as an act of love, calling it a simple yet profound way to care for one another. And so whether we agree or not with the various religious leaders out there, they still have a profound impact on the population. And so collaborating with them is one way that has proven success. Going on to the next slide. I'm going to do a quick overview of a case study in terms of measles outbreak and disease resurgence, right? Because we know that this is one of the greatest public health costs, is when diseases that have for decades been under control start to rise again because people get complacent and they don't get the MMR vaccine. So measles, of course, is something that the MMR vaccine is very effective. against. However, following the publication by Andrew Wakefield about at that time he claimed there was a link to autism. That paper was only retracted in 2010, and it has done so much damage in terms of parents trusting the MMR vaccine. And there's lots of evidence to show that he had lots of financial incentives through anti-vax groups to make those claims. So we're still dealing with the fallout from that. If we then go back to 2019, there was a severe measles outbreak in Samoa. Samoa is a country in the central South Pacific Ocean, and it is amongst the westernmost of the islands countries of Polynesia. Measles has a very high reproductive number. So the R0 values between 12 to 18. That is so much more infectious than COVID. It's in another league. It's highly, highly contagious. And you need very high herd immunity in order to protect the overall population. So it varies by disease. For measles, you need 95% coverage in order to prevent measles outbreak. As soon as it starts to dip below that, we're in trouble. And similarly, it's very high for polio too. So in Samoa, there was a national emergency due to an outbreak with over 5,707 cases and 83 deaths, and tragically, primarily in children under 5 years old. And this outbreak happened shortly after RFK had visited Samoa, and he is a very prominent anti-vaxxer. So in that instance, they had to respond quickly with a mass vaccination campaign, which was conducted during a national lockdown in December 2019. So the measles outbreak was so bad that they had to go into lockdown. Hospitals were overwhelmed. International aid and emergency medical teams were sent from New Zealand, Australia, and Japan. And it cost the country significantly, an estimated 10 million USD in direct costs for outbreak management. And the overall economic impact in Samoa was a total of 22 million. So again, looking at vaccination being preventative, it's the best way to save money for your healthcare system. There was very low vaccinations rate at only 31%. So imagine you need 95% for herd immunity. And in this region, they had only 31% due to aggressive misinformation and vaccine hesitancy. And if we look at the cost of a measles case, even in the United States, it's about $32,000 per case. So that is a significant cost to the healthcare system. Even a 5% reduction in MMR vaccine coverage can lead to 3 times fold increase in annual measles cases. So you need to have a really tight grip on measles and ensuring that there is a high uptake amongst the community. When we think about the costs overall, so the 22 million that it costs Samoa, it's because of things like government expenditure on vaccine campaigns, the logistics, how the tourism sector is then negatively affected, and that depresses the economy. Productivity loss. Again, measles is something that mostly affects children, and thousands of workdays lost due to illness and caregiving responsibilities of the parents. So the lessons learned here is the strengthening of immunization programs and combating vaccine hesitancy, critical for outbreak prevention. So you have to almost be on high alert all of the time. Measles was almost eliminated in 2000 in the US, but then prior to that, it was associated with about 10,000 hospitalizations and 500 deaths annually. But so that's prior to 2000. We got to a really good place, and then again, declining rates means that cases are back on the rise. And we look at the year 2024, in the first 4 months, there was more cases of measles in the first 4 months of 2024 than all of the cases in the US in the prior year. And there was a death in Canada as well. Whoops. So that, I'll just go back a slide very quickly. This is just to show you that overall there has been a decline over time, that this used to be a very significant killer, particularly of children, but that if you look on the left, you see in the US, both the death rate has gone up since 2000 to 2015. And again, with post-pandemic, we see that those numbers are going to dip down again, and the reported cases of measles. Now, to put this into context, of course, overall, the living standards are also had improved during that period, particularly if we're looking on the left-hand side from 1921 to 2015. Therefore, it is a combination of vaccination coverage, but also improved living standards and sanitation. In the UK, to give you a different example, we also had a very significant measles outbreak in Merseyside, where, again, the uptake of vaccination fell from 92% in 1996 to 80% in 2003. As a result, in 2012 to 2013, there was a very large measles outbreak that cost the UK 4.4 million, and is 20 times the cost of the vaccinations that it could have prevented. So MMR in particular is linked to social media misinformation, disinformation, and that's Andrew Wakefield being one of the names associated with the initial skepticism around MMR. But it's a very expensive misinformation issue. So currently, 6.1% of children have not received the MMR vaccine in the UK. So if we look at, there have been efforts to increase the number, but we are still seeing that we're not quite at the target, and that susceptibility tends to cluster in deprived neighborhoods where the highest numbers of children are unvaccinated. And this kind of means that there's an ongoing measles outbreak risk as these children get older and leave secondary school and mix. So again, even in the UK, although that was probably the peak in terms of measles outbreak, there has been an increase in vaccination, but we've still not reached that target yet. Another area of concern are vaccine gaps for things like pneumonia. And pneumonia is one of the most common causes of death worldwide in terms of a respiratory disease. It can develop from a range of different infections, from viruses, bacteria, and fungi, including Streptococcus pneumonia. But it is related to others as well. So the pneumococcal vaccines protect against pneumonia from the Streptococcus pneumonia bacteria, and that again is one of the major causes of children in under 5 who develop respiratory infections. So there is the pneumococcal conjugate vaccine, the PCV, which targets different serotypes of again the virus. So in some countries, PCV is given to children younger than 24 months, but this varies. For some countries, PCV is given in older children, and in other countries, they may even only be focused on the elderly population, since they are at the highest risk, and this risk continues with age. It's the second most common leading cause of hospitalization in the United States. And with severe pneumonia, mortality rates go up to 20%. And even a year, and if you look a year following that, the mortality rate goes up even more to 33.6% mortality rate. Again, we see the US has a more comprehensive immunization schedule for PCV, but the lag is greatest in the minority groups that don't take it up. If we look at PCV 13, this has a 65.2 unadjusted effectiveness against pneumococcal cap in the age of 65 to 74 age group. So one of the most important things that the pneumococcal vaccine is effective against is not only the milder illnesses, but most importantly, it protects against pneumococcal invasive disease, which is more severe. And this severe form of the disease develops when the bacteria moves from the upper respiratory tract to other parts of the body, such as the blood and the cerebrospinal fluid and the pleural cavity, which are usually free of pathogens. So again, if we then see the effectiveness of the PCV vaccine against this more aggressive form of invasive pneumococcal disease, it's 80% effectiveness. This chart here looks at how effective the estimated annual deaths that could be averted by pneumococcal vaccination in children. So again, the most vulnerable groups being the young and the old. And so there's a significant amount that if we increase the pneumococcal vaccination coverage, we close that gap, many more lives can be saved. Once again, the global south in particular would benefit most. So 27% of lower risk of pneumonia diagnosis in vaccinated children and 11% a less mortality rate. So good evidence in terms of receiving the pneumococcal vaccines for both children and elderly. Here we have a graph of death rate from pneumonia for all age groups and particularly amongst the 70 plus, which we can see here, the annual death rate. So on the left, we have the death rate from pneumonia in Poland versus in Europe. So the purple line here is 70 plus, and then we can see these other colored lines correspond to different age groups. So the top line is for 70 plus, and then 50 to 69. You can see those numbers going down all the way to 5 to 14 years. So again, much more dangerous in the elderly. And we see here that there are, compared to the European average, Poland has more deaths per 100,000 people, which again signals that there is an opportunity to reduce this figure by closing the vaccination gap. Go to the next slide. So this brings us to kind of summarize the key takeaways from today's talk. One is that I'm in agreement with the WHO that vaccine hesitancy remains a top public health threat, even more so actually after the pandemic, because it'll be critical for not if, but when the next pandemic happens, and that there's significant economic consequences also related to this, and that misinformation, disinformation drives distrust. And so there's a lot of work for us as healthcare professionals to rebuild that trust and educate ourselves in order to educate patients, co-administering flu and COVID vaccines, promoting best practice, ensuring that people are up to date with their routine immunizations, and including things like PCV vaccines. Pharmacists, doctors should also be working with public health agencies, youth groups, leveraging technology and social media, because there is a lot to come up against. The general public now is very into mediums and modalities like podcasts. And so it can't just be Joe Rogan talking about these issues. We also need our scientists and experts to get out there and engage with the public. And sometimes, particularly amongst pharmacists, there is a hesitancy to do so. And also improving the quality of research to counter vaccine hesitancy, particularly amongst ethnic minorities and vulnerable groups. I suppose my final point is that in order for us to rebuild trust with the general public, we have to acknowledge our own role in historical malpractices and call out where there have been errors that have been made. So I think that aspect is much more challenging but necessary. and to ensure that the appropriate regulations are in place to support that. And finally, my message to you in our last minute is to be a vaccine champion. And anyone can be that, from a student to a consultant. We know that vaccines are one of the greatest public health innovations. We started our talk to say that it's been the single greatest innovation in terms of extending not only life expectancy, but quality of life, and productive for the economy as well. That we have a huge amount of data, particularly post-pandemic, in terms of safety and efficacy, that it works quickly, it's the best way to boost your immune system, and that everyone can have a role to play in keeping each other safe. So that's also key, that we should be working with patients to be also vaccine champions. And that when you do have people who come to you with questions, that you should always remain kind, empathetic, and compassionate to meet people where they are, even if they sometimes say things that you find difficult to believe. So it's in all of our interests to combat vaccine hesitancy, because an outbreak anywhere is an outbreak everywhere, and none of us are safe until we are all safe. So here are my references. There's some excellent studies that I think, if this is an area that you have a lot of research in, interest in research in, I highly recommend that you have a look. Thank you very much for your time, and I hope you've enjoyed today's session.
It was fabulous. Thank you, Oksana. Just a few questions. We also try to perform a research in Poland about vaccination hesitancy among pharmacists, and one of them was religious views, unfortunately. Do you just have the same problem in the UK? That religion, I mean, I'm talking about any kind of religion, not really Christians, because mainly we're Christians here in Poland. Do you see kind of problem in the UK?
Well, as we saw that the data showed that there were certain minorities with religious beliefs that had the highest rate of vaccine hesitancy. Sometimes that's also due to what they believe is in the vaccine. So certain animal products, they think that they're disrespecting their religion by getting the vaccine. So that's why it is so instrumental to have them as partners, because they can then say, actually, the religious scripture doesn't say anything about not getting a vaccine, right? But that's why you need to have that partnership and that good relationship to do so. So that data that I presented, particularly amongst the ethnic groups, that was the early response. They were able to shift that quite dramatically by engaging with those groups. So finding, I guess, the people, and I suppose not all religious leaders are going to necessarily want to, but I'm encouraged by the fact that Pope Francis, again, had like a positive message there. And religious reasons are definitely tied to vaccine hesitancy, but that doesn't mean that you can't turn that around by bringing in religious figures. I think that's like the main strategy for that.
I think it would be a brilliant idea just to involve the church. I mean, I think 2 weeks or 3 weeks ago when I was visiting UK, I visited the church where pharmacists were performing vaccines, but obviously the bishop probably had to agree on that.
Of course. That
was an excellent idea. Another good story we have also in Poland is the vaccination among the medical students. It's another problem we have, and they also they had sort of imagination about like how the vaccine was created, and like there were lots of just picking up a lot of fake news as well. And what is your opinion about like pharmacy students or medical students? If you have any kind of idea, do they like are they afraid in the UK? Is it the same as in Poland, or they are more like level-headed, I would say?
Well, I don't have like data to say about what the students think. I think there's always going to be some level of people who just want to be devil's advocate and disagree. But I think on the whole, there is, like, for instance, when I was running the vaccination training, huge interest from our student population to become vaccinators. So I would say that at least in my microcosm of experience, it seems to be less less of an issue amongst our students. But that's not to say that, again, young people sometimes feel like they're already healthy. Why should they take the vaccine if they don't think that it's like low perceived risk? But one thing that we still don't understand is why people who had mild case of COVID, who were not hospitalized, who are healthy, who have no underlying conditions and are young, developed debilitating long COVID. And we have many long COVID clinics. Like, this is still a somewhat, we're not understanding. We think it has to do with some clotting mechanism, but it's a gamble. And so in terms of, I would say with students that are resistant, I think it's sort of getting them the challenge of presenting the arguments about the technology, the development. Like, for instance, mRNA wasn't originally designed for COVID. Like, the researchers in Germany from BioNTech were looking at cancer. And now even we see certain types of skin cancer, melanomas, have great success with mRNA technology. So I don't think there's a particularly easy answer about what to do about students other than involving them.
Yeah.
You know, bring them in.
Yeah. My last question is, are you, if I understood correctly, you teach students vaccinations at the university?
So this was during the pandemic, because there was a way we don't have, there's like a subclause that meant you could become a non-registered vaccinator. So we are moving in that direction, and we did it as a sort of, we integrated students into the vaccination workforce in the emergency phase. We are out of the emergency phase, and now we were developing it into our curriculum so that they are certified vaccinators by the time they graduate, and they have that like practical experience.
I think this was a Canadian example. They also had some vaccination hesitancy among the basically pharmacists, and they swapped basically teaching from postgraduate to the undergraduate. Yeah. And they made lots of basically good feedback from this. I think it would be a very good idea to do it also in Poland, because now it's postgraduate, and just try to do it at the university when they are still studying, when they are still motivated, and I think when they are still very open-minded to change their mind.
Yeah. No, I agree. I think even if we look at like the basic concepts of vaccines, not even the ones who have become vaccinators, you know, I think that needs to be covered as young as we can, like in even middle school. So, and we can't get complacent about it. That's the thing. Like, people don't remember the iron lung for polio, right?
Yeah.
If you have friends who have, like, you know, being disabled due to a infectious disease, you know, you see it in a different light. And I think we're almost, again, there's the cycle of like being able to nearly globally eliminate polio, right? It's still in like Afghanistan and pockets here and there. I think there was a case in Gaza, and but on the whole, you know, we're so close to eradicating it like smallpox. And as a result, people forget how debilitating infectious disease are. And there is for this belief that people think that they're somehow weak if they have to get it. And that is difficult to overcome. There's certainly no quick fix for vaccine hesitancy. I think that was the point I was trying to get across. And I can't explain why women are more vaccine hesitant than men, according to the data. But you know, that's something I think needs further research as well. Yeah,
I mean, I really enjoy your presentation. It was super professional. So thank you for all the thoughts, and this is really like spotless. I actually agree. You're the best.
Thank you so much. It's such a pleasure, and I hope we can do it in person soon too.
Absolutely, absolutely. I'm looking forward to our cooperation, and thank you very much for being with us today. Thank you very much.
Thank you. Bye.